I'm Nick Kman. I'm an emergency physician at Ohio State. You guys are all emergency physicians. I get in the habit of saying that. But I'm a pinch hitter, so I'm going to lead this off. My name isn't on the slide, and the reason I have a mask on is we had a COVID exposure within our group, and unfortunately, Dr. San Miguel, who was supposed to give this talk, is not able to. I'll just leave it at that. But we have a great group of residents, and then our colleague Allie is not at the conference today, but she really put together the lion's share of this talk, and so I'll have the residents maybe introduce themselves when they give their part. I think this is going to be really fun, and when I was asked to give the talk, I didn't know much about it, and then I started looking at it, and this would definitely be something that I would come to, so thank you for coming. The things that we're going to talk about today are going to be really helpful in a very busy shift to deliver a little bit of content to your learners. As a group, we have no disclosures. What we're going to do is talk about different ways to deliver little nuggets of teaching to your students and residents while you're on shift. And you're going to get a chance to try all of those out, which is really fun. We're going to talk about micro-teaching methods using gamification principles and role play. So Allie's been helping a lot with our emergency medicine clerkship with gamification, and the students really enjoy everything that she's been doing. This is going to be experiential, so we're going to apply these teaching methods, and hopefully you can bring them back to the place where you're working. So one of the first things I do, so I don't know about you guys, but at Ohio State we have many learners of many different levels. So we have a Med 3 selective, and we have a required Med 4 clerkship. We have a residency, we have an EM-IM residency, we have fellows, we have rotators. And so I think the first concept, before I get into the different methods that we're going to talk about, is to really know who your learner is. And if you guys don't mind bearing with me, I would like to do a little bit of that right now. So since we're a small crowd, if you could maybe just say your name, institution, and the type of learners that you work with. Is that all right? Can you want to lead us off?
Hi, I'm Mama. I'm at The Ohio State University as well, and it ranges from med students, rotators, to senior EM residents.
Great. Adam?
Adam Ross from the University of Louisville, and kind of all those things, as well as we have some undergrad students.
Okay.
I'm Natalie Elder. I'm at UC Davis. I'm the University of Vermont next year.
Are you a fellow now?
Yeah.
Oh, great. Okay. Maybe go to you and then across.
Crystal Bass, also at The Ohio State University, pediatric emergency medicine healthcare, and all levels of careers.
Great.
I'm Kaushika. I'm from Sri Lanka.
Great.
So I'm an emergency consultant at the last hospital in Sri Lanka. So we have trainings from medical students, nursing students, emergency residents, and all the specialties.
Wow. Well, welcome. Thank you.
Hi, I'm Kelly Meyer. I'm a med student at SIU in Springfield, Illinois, and so I believe they work from M2s up to maybe fellows, but I'm not positive.
Okay.
Hi, I'm Kathy Chase, I'm a pediatric emergency medicine attending at Postit Notes. We have learners from medical students all the way through PCM fellows.
Okay. Go ahead.
I'm Ajay. I'm an ultrasound fellow at Northern University Hospital in Manhattan, New York. And yeah, all of them are here.
Great. And finally?
Isabel Brana, also at the Shore University Hospital, and we have coordination with the PA students.
Okay. And how about our medical student ambassador?
All right, I'm a medical student. My name is Krishna. I'm actually from Kman, Carolina. I'm not entirely sure what kind of careers, but the hospital I did rotation job, we had not only medical students, but also nursing and PA students.
Wonderful. So I'm going to talk about the 1-minute preceptor kind of first. So one of the first pearls that I would offer you is, in your career as an educator, you're going to be evaluated by your learners. So the first thing I would do is get a hold of what the evaluation looks like and see what's on it. I can tell you that at Ohio State, we have a standardized evaluation of clinical instructor. And one of the first questions is, did this instructor clearly set goals? So you want goals or a commitment from your learner. You want that person to commit to having a goal for that shift. So even when I work with the residents or the medical students, we might ask, what do you want to work on today? And it's common for them to say, my physical exam skills, my differential diagnosis, I want to do more procedures. So get a commitment to the learning plan from your learner. That's the first thing you want to do. And get them to commit to a plan. So one of the things that we talk to our learners about is when they present a patient, we want them to commit to the plan. And it might not be the right plan. So they may say, I want to do full body MRI and admit the patient. But that's better. And depending on which of our attendings you're working with, that might be the plan. But I'd rather have that than say, I want to discharge the patient, and not commit. So get a commitment, and then ask them why they feel that way. So what about your physical exam led you to this conclusion? So probe for the supporting evidence. It's very important when we teach our students and our residents that we ask a lot of questions about the presentation, because the presentation is the surrogate for us being in the room with them. So if we're not able to do direct observation, I have to ask you. So patient comes in with a headache, tell me your neuro exam, and they tell me it was normal. And then I ask them, well, what did you do? Because I don't know what your neuro exam is. Did you walk the patient? So what's the evidence that I want to admit this patient? And then reinforce what was done well. So I really like that presentation. I agree this sounds like a migraine. The patient doesn't have, meningismus. I agree with IV fluids and a migraine cocktail. But also, did you ask the patient about the onset of the headache? So I didn't hear that you asked if it was sudden or delayed in onset. And then teach a general principle. So, I don't know if you know much about, migraine cocktail, but the reason we give dexamethasone is there's literature to show that, it helps decrease the incidence of rebound headaches or something like that. So that's kind of my part of this. I think Ryan's up next to talk about a different tactic. So I really like that one, but you're going to hear some different ones, and you'll pick maybe one or two that you like better.
Thank you, Dr. Kman. I'm Ryan O'Neill. I'm a PGY1 at Ohio State. So I'm going to be telling you guys about the SNAPS model, and you'll notice there's actually a decent amount of overlap with some of these other teaching methods like 1-minute preceptor, and these things don't really exist in a vacuum. They kind of are just however you personally prefer. Like if you like one more than the other and it works better on shift and it works with your flow, then you're more than welcome to use that one. But this one just starts with summarizing the H&P. So it's like a very learner-centered approach. So you're going to be having the student, like he said, kind of commit as someone that's guilty of like the soft, like, I don't know what I'm going to do with this person. Maybe they'll tell me if I just bait them along. But yeah, so you have the med student or learner summarize the H&P for you, and it's just going to be like 2-3 minutes. It should only take like maybe half of the learning time. It's like a 5-6 minute interaction, just because we're all so busy on shift. And once they've given their whole story, you're going to have them narrow the differential. And again, this is kind of getting them to commit. So narrow it down to their like top 2, maybe 3 that they think it's going to be. And then once they've committed to that, then you're going to push them a little further, and this is your chance when they analyze the differential to see them kind of think out loud in front of you and analyze their thought process and see how they came up with that from their history, their physical, like all their past experiences. And this is when you're able to kind of see where they're actually at, and you're able to find some points where you can intervene. So once they've analyzed the differential, you can then push them to kind of pick their like number one. And then from there, you can go to probing the preceptor. And then this is when more of the kind of back and forth happens. So before it's kind of the student just giving you all the information, giving you what they think. And now for probing the preceptor, they get the chance to say like, hey, I had a question about this. I'm not sure if this is the right way to do this. And this is when you can kind of share clinical pearls and have that back and forth conversation to help out the learner with getting to that point as far as the H&P, developing the differential. And then from there, once you've nudged them in the right direction as far as their differential, then you can start discussing the plan. And again, this is having them commit to a plan, like he said. If it's completely wrong, just make sure that they own it, because I think, in my experience at least, I've grown a lot as a clinician with the attendings that make me come up with a plan and commit to it 100%. So once you've done that, you can kind of give feedback on their plan, obviously, and it's, again, a conversational part of it, just like analyzing the differential or probing the preceptor. And once you're all done with that, you can kind of look through the whole process as a whole and work with the learner to identify any points of weakness. And from there, you can kind of come up together with some self-directed learning. So find a weakness in the whole presentation or a topic they want to learn more about, and then kind of send them in that direction. And again, take 5, maybe 6 minutes. Obviously, you can't do it on every patient in the ED, but if you can just do a couple of these per shift, I think it's just helpful. We do this stuff so informally. Just having a structure that you can use and that you can also give to your other resident teachers is really helpful. So this next one is illness scripts. This was something new to me. It's something that I think we all do. It's part of our clinical practice, but a lot of us don't break it down this way. So what it is essentially just the mental models that we use to function in the emergency department. And this is something that you kind of just build up over time with years of learning, clinical experience. And we all have these heuristics that help us function more efficiently in the ED. So when I would ask you to imagine like the quintessential MI patient, you could probably all come up with a similar picture, but there's going to be some variations between like what the med student's picturing versus what an attending would be imagining. There's just, I think, a little more nuance because you get those patients over years that you see like just a weird presentation that you think back to. So it's just like a helpful way to organize a patient approach, and this breaking it down into these fundamental components, it just gives you a lot of different ways to approach teaching, because you can find probably in almost any learner a deficiency in one of these things, and that's kind of a good point of conversation to have with them. And you can also target it to like the correct level. So if you have a first, maybe second year medical student working with you, you might be better off just sticking with the pathophys and just talking about the anatomy, physiology, etc. Versus like if you have soon to be attending, you might want to go more into like interventions, like what if questions, and expound on that. And then like epidemiology stuff, you can expound on doing like social determinants of health. So I think just breaking down those mental models that we use and actually like writing it down and seeing it on paper and then having the learners go through it with you can be a helpful way for them to approach it.
Did you want to go through our practices? Yeah, I'll come up there.
So I'm Cami Walters. I'm one of the PGY2 residents at Ohio State as well. To kind of illustrate the illness scripts, we were going to go through just a quick like practice presentation. So Ryan's going to walk me through an illness script here. I'm his, let's say, third-year medical student. So Dr. O'Neill, I just saw this patient. He is a 55-year-old male. He has a history of GERD, also hypertension and hyperlipidemia. He's coming in today for chest pain. He said that the pain was sudden onset, kind of lower in his chest, a bit into his belly. He's also having some nausea as well as some burning feeling in his abdomen. His vital signs were all normal. He had a benign abdominal and cardiopulmonary exam for me. So I think what's going on is I think that he has GERD, and I'd like to give him a GI cocktail and some Zofran and try to send him home.
Okay, excellent presentation, Cami.
Thank you.
So just going back to kind of your differential there, you're talking about GERD. What would, like when you picture like a patient with GERD, like versus, I don't know, say a heart attack, what do they look like to you? Is there like a common age, sex? Like, what does a patient with GERD to you?
Potentially like younger, middle-aged, maybe overweight or has bad eating habits, I would think of.
Okay. And then if you were to describe like their symptoms, like their pain, when you talk about that, how does that present normally?
I would usually think like epigastric pain or maybe abdominal pain.
Okay. And if we're talking about a more serious cause, about a heart attack or about chest pain, what would you think of then, like as far as age, gender, anything like that?
I guess given this patient's age and risk factors, I would also think about an MI, even if they're complaining of abdominal pain as well.
Okay. So part of their medical history, maybe?
Mm-hmm.
Okay, comorbidities. Okay.
Yeah. Cool.
Yeah.
So on a similar topic, if you guys are teaching your students about the presentation, CDEM, Clerkship Directors in Emergency Medicine at EMRA, did a video together about 5 or 6 years ago on presenting your patient. And it's on YouTube and Vimeo. And that video, we have our students watch it during orientation. It does a really good job of teaching the students how to pull the pertinent things into the illness script, right? Because what they were trying to illustrate is we want to hear, in a 3-minute presentation, the pertinent things that are related to the chief complaint, and that's what these illness scripts try to do.
All right, so my name is Lauren Willoughby. I'm currently one of the chief residents at Ohio State, and in just a few short weeks, I will be starting as the medical education fellow at University of Wisconsin. So I'm going to walk us through a couple other teaching methods. So the one that's up on the slides right now is whiteboard teaching. So this is really beneficial because students will actually feel like they're deliberately being taught. With some of the models we went through before, sometimes that can get missed on shift as actual teaching that's occurring. But if you set out to kind of go through and make some illustrations, if you're good at drawing, you can even put some pictures in. But this gives like the students that actual like I'm being taught feeling. So here we have one of our senior residents teaching about EKGs. The other examples we have up here is the heart score and then what diagnostic tests you can do if a patient does not have a gallbladder but is having that right upper quadrant pain. So the biggest benefits to this is that you can highlight like key points. If you have a big whiteboard like that one, you can write as much or as little as you want. But the drawback to it is obviously you need the supplies. So you'll have to be somewhere where you either have a whiteboard. We have these little mini whiteboards here too. But you have to be in like a designated space to do this. And as opposed to that, we have the Postit pearls as well. So I think this was really brought into light by Michelle Lynn, who kind of developed this. But basically, it's very similar to the whiteboard teaching where you're writing down key points. The biggest benefits to this is that a Post-it note you can pretty easily have in your pocket. You can do it pretty much anywhere at any time. So after a student presents a case, you can go through and kind of highlight the biggest high yield things that you covered. And then you can always leave this up. So you can leave it on walls, on computers, and other people might be able to learn from it later on too. Sometimes it's a little hard out of context, but here the one that we did was for stroke treatments. So if this was to be left up somewhere, you could really easily just look at the last known well and kind of like the things that we highlighted as being important. So yeah, those are the two teaching methods that we'll be able to practice a little bit today too with some of the supplies that we brought. So we do have this QR code. So what you can do is you can scan it. It'll take you to an app where we'll just practice like anything that you feel like you commonly teach. Sorry if I'm in your way. Anything that you commonly teach on shift, just try writing down like the key points that you would want the learner to take from it. And then once we do this, we'll be able to look at everyone's Post-it pearls up on the screen through the app.